Thanks for having me today. So I'm going to present the clinical outcomes of a novel protocol that we established at the University of Iowa to objectively evaluate patients presenting for bariatric surgery with subjective symptoms of gastroesophageal reflux disease. I have no disclosures. So as we all know, obesity is increasing in prevalence in the United States, and among other comorbidities, gastroesophageal reflux disease is quite common in this patient population. In addition, GERD symptom severity, as well as the associated pathological sequelae of gastroesophageal reflux, increase with increasing body mass index. And I think we all know here that bariatric surgery has by far been shown to be the most effective treatment for obesity and obesity-related comorbidities. Now, recent evidence and more evidence is emerging that would suggest the two most commonly performed bariatric procedures done in the world, the sleeve gastrectomy and the Roux-en-Y gastric bypass, have similar long-term results. However, where there is some ongoing disparity and debate is the effect of both of these procedures on gastroesophageal reflux disease, and specifically the sleeve. The Roux-en-Y gastric bypass has long been the gold standard procedure for individuals presenting with obesity and associated gastroesophageal reflux disease. However, the treatment of gastroesophageal reflux disease in this patient population with a sleeve remains controversial in the literature. And there's increasing evidence, as the previous presenter alluded to, as to increasing rates of worsening GERD after sleeve gastrectomy, de novo GERD after sleeve gastrectomy, increasing rates of Barrett's following sleeve gastrectomy, and by far the most common long-term reoperation in patients that have sleeve gastrectomy is conversion to a gastric bypass for reflux. In addition, there is inconsistent evidence to suggest a specific preoperative protocol in the evaluation of these patients and whether establishing a preoperative protocol would have any impact on the ultimate decision-making process in terms of which procedure these patients ultimately undergo. So we aim to create an objective protocol to preoperatively evaluate these patients who are presenting for bariatric surgery with symptoms of GERD in order to hopefully optimize procedure selection in this group and to risk stratify those patients presenting with GERD symptoms who wish to have a sleeve gastrectomy in order to counsel them better and hopefully optimize procedure selection in this population. So we endeavored to study this protocol again to see whether it impacted procedure selection, and we wish to add to the overall literature regarding the prevalence of foregut pathology. So this was a retrospective review of data that was collected prospectively from a protocol that was rolled out in real time in July 2016, and I'm going to show you the protocol here now. So as you can see, patients who presented to our program for consideration for bariatric surgery with subjective symptoms of GERD underwent typical bariatric evaluation, full history and physical exam, meeting with a dietitian, meeting with psychologists, meeting with our clinical educator. And at that time, those GERD symptoms were characterized on history. Following this, patients were deemed to either be better candidates for a specific procedure at that time, so based on just history, physical, typical bariatric evaluation, they were deemed to be better candidates for sleeve gastrectomy or bypass at that time, or they elected to defer that decision to a later clinic appointment, either following testing results or for other just patient-specific factors. Now, after this evaluation, all patients were ordered an upper endoscopy and an esophagram. Esophagram to evaluate for anatomy, specifically hiatal hernia, and upper endoscopy to evaluate for sequelae of GERD, i.e. esophagitis or Barrett's. Following those two tests, if the patient desired a Roux-en-Y gastric bypass, then that was the procedure the patient ultimately underwent, as we feel that is the gold standard procedure for this patient population. However, if the patient desired a sleeve gastrectomy, we recommended further testing. And the testing we recommended was in keeping with objective pH testing with Bravo testing, as well as esophageal manometry with high-resolution esophageal manometry. Now, if those tests were normal and the patient still desired a sleeve gastrectomy, we felt that was permissible in this patient population. However, if there was abnormality noted on those tests, we would recommend a Roux-en-Y gastric bypass. So we collected patient characteristic data in patients who were eligible to go through this protocol. We looked at whether people were compliant with undergoing these tests and going through the protocol. We looked at obviously the results of the tests, and then finally we looked to see whether the procedure selected was influenced by protocol testing. So this is a busy slide, but I just want to show you that overall we identified 133 patients that would have been eligible to progress through this protocol. All of the patients were overwhelmingly female. Our average age was 43, and 82.7% of the patients that presented were on acid-suppressing medications at the time. With regards to compliance, so of the 133 patients that were identified that would have been eligible to go through the protocol, 98 of them actually initiated the protocol, so 73.7%. 75 patients, or 56.2% of the eligible patients, underwent EGD and/or esophagram only. 24 patients underwent pH testing and/or manometry, and 17 patients underwent all 4 objective tests. So what did we find? So similar to the previous presenter, we found that pathology was identified commonly on these tests. So if you look at our EGD results, we found that 4% of patients undergoing upper endoscopy had Barrett's esophagus. Grade C or D esophagitis was identified in 18% of patients, and a significant hiatal hernia in 36%. In patients who underwent esophagram, we found the prevalence of significant hiatal hernia to be 42%, and dysmotility almost 14%. And in patients who underwent manometry, previously undiagnosed motility disorders were diagnosed 41% of the time, and abnormal Demeester scores were identified on pH testing 83% of the time. So did this actually change what we ultimately did? So I'm going to take you through this graph here. So as you can see, we identified 133 patients that presented to us for bariatric surgery with subjective symptoms of GERD. Of those 133 patients, 93 of them were deemed at the time of their initial evaluation to be better candidates for sleeve or bypass. 38 of them were deemed better candidates for sleeve, and 55 were deemed better candidates for bypass. 40 patients elected to defer that selection following testing or for other personal patient-specific factors. So then those patients went through the protocol. And then on the far right, on your far right, this is the final procedures that they ultimately underwent. So you can see that the patients that had a predetermined procedure already selected, ultimately 34 of them underwent a sleeve gastrectomy and 59 of them underwent a gastric bypass. So what this means is 10 of these patients ultimately changed which procedure they had, and we found that 8 of those 10 patients that changed procedures did so because of the results of our protocol testing. So on the bottom row there, the patients that deferred their decision-making process, sleeve gastrectomy was performed in 16 patients and gastric bypass was performed in 24 patients. And what we found was that of those 40 patients that deferred their decision-making process, 25 of them ultimately selected their procedure based on the results of protocol testing. So what does that look like in numbers? So of the patients that ultimately changed their procedure, that was done 80% of the time due to the results of our protocol testing. In the patients who elected to make a procedure selection at a later date, pending test results, the decision that they ultimately had or the procedure that they ultimately underwent was based on the results of protocol testing 62.5% of the time. So overall, in all 133 patients that presented to us that were eligible to go through this protocol, the ultimate bariatric procedure that was performed was determined based on the results of our protocol testing nearly 25% of the time. So what do we conclude from this? Essentially, foregut pathology is common in obese patients, especially this patient population, and that implementing a comprehensive objective evaluation of foregut pathology aids in counseling these patients and aids in regarding the preoperative optimal bariatric procedure selection. And overall, this novel protocol for foregut evaluation did have a meaningful clinical impact on the ultimate procedure selection in this patient population. So there's obviously a number of limitations. It's a retrospective database review. This protocol was established in real time and rolled out, and so there was obviously an adoption period. Patients didn't have these tests funded, so whether they underwent the tests ultimately obviously was based on their own autonomy, which was respected at all times, but obviously was based on patient resources and insurance and things like that. In addition, as what's been alluded to before, subjective GERD is variable. We didn't use any questionnaires to evaluate those symptoms, but I would say that probably reflects real life. I think a lot of people that present have their GERD symptoms evaluated on history and physical and typically not questionnaires. In addition, The optimal procedure was often apparent quickly after even 1 or 2 tests. And so the motivation for those patients to undergo further testing once they already had a procedure recommendation was obviously not very high in this patient group.